Okay, next we have a little reshuffle. Next, Dr. Sowmya is going to present Don't Cross Your Eyes to Diagnose Crossed Eyes in Children.
Good afternoon, everybody, and thank you for the opportunity. So I would be discussing on Don't Cross Your Eyes to Diagnose Crossed Eyes in Children. This is going to be a comprehensive topic covering all the things about esotropia. So most of the times when we see a squint, apart from the squint specialist, all of us start having a dizziness, especially in a general ophthalmic clinic. I'll be covering this topic in the following headlines, looking at diagnostic caveats of importance, what are the surgical caveats that we look at, a couple of cases to understand them, and summing up on a take home. The most important things what we'll cover up with the cases would be diagnostic caveats. You should always use fixation targets when we are measuring or when we're evaluating a squint in a child. Apparent limitation of abduction is something that always has to be kept in mind in any case of esotropia. The high AC by A ratio, the importance of cycloplegic refraction, the distance near disparity and the gaze angle disparity, the palpebral fissure changes and signs of co-contraction, and the fundus examination. So these are specific points with respect to esotropia apart from the regular points that we look in a squint evaluation. So first and foremost, confirm the esotropia. However, the younger the child, always perform the alternate prism cover test. You can use any of the fixation targets you use. This child is apparently referred for the squint and the child does not have any squint. Besides, this child needs a little time to play with the child before you actually elicit the esotropia. Don't use occluders, don't use your entire hand, use a thumb according to the size of the face. So you see that the child starts, you see that ET coming in. So first confirm the esotropia before you proceed on. The next important thing would be to use fixation targets. So this child again come with esotropia. The moment you ask the child to start reading is when the esotropia comes in. So always use fixation target before you jump in and or use your torchlight. So again, use both for distance and near, the fixation targets which are normally used for vision charts which are kept in the clinic. So that could be used for confirming it. So the first and foremost important, use vision targets. Second important caveat, in any case of esotropia, the most important point apart from doing an alternate prism cover test, knowing what is the amount of distance and near deviation. Like in this child, it's a 3-year-old child with 35 prism types of ET for distance, 45 for near. Most important thing, that information that you would need is a cycloplegic refraction. You can use atropine in less than 5 years of age or a cyclopentolate, however you're comfortable with, and look at the cycloplegic refraction, and that gives you a diagnosis as refractive accommodative esotropia. So that becomes the second caveat. Similarly, even in an older child, like this child who is a little older child, coming with a similar complaints, ocular movements being completely normal, look at the cycloplegic refraction before you conclude the case. So cycloplegic refraction must in any case of esotropia. The third important thing is apparent limitation of abduction. So if you have had ET for a very long time and you check the version movements, you are going to find that the abduction is limited or the levoversion and dextroversion is limited. Like in this child, though the video is taken post-dilation, you see there is an apparent limitation of both dextroversion and levoversion. The easiest thing to do is to cover one of the eye, check for the adduction movements, confirm that it's an apparent limitation of abduction, not a true limitation of abduction. That helps in your diagnosis again, that it's not something dealing with a 6-nerve palsy or a DRS that you're dealing with, and helps you to come to a conclusion. The next important thing would be high AC by A ratio. This child, look at the child seeing through the distant glasses and near target. There's obviously an esotropia, which is around 20-25% diopter. Bifocal glasses corrects it. So looking for distance correction when you're given a hyperopic correction, look for the near deviation again. Check with +3 lenses if there is any difference which is made in the angle. So distance near disparity, again, think of two important things. One, if there is normal ocular movements, it's usually a high AC by ratio. If it is an abnormal ocular movements, then you obviously know the cause. The next important thing would be when there is an abduction limitation. Like in this child presenting with esotropia, has a definite limitation of abduction in the left eye and a gross esotropia, versus this child which has abduction limitation of either of the eyes. The most important feature would be here a palpebral fissure changes, which is apparently seen in the second case versus the first case. So that brings us to the most important thing. Whenever there's a limitation movement, a limitation of abduction, always look for if the primary gaze deviation is in par with the limitation of movement. If it is in par, then you're dealing with 6-nerve palsy, not a DRS. If the movement limitation is same along or there is a difference. If you look at the first case, the movement limitation is almost the same in up gaze and in the down gaze. Versus this child, if the down gaze movement, abduction movement is much better than the up gaze movement. So that again helps us understand that it's a DRS case versus a 6-nerve palsy. And look for signs of co-contraction, which is palpebral fissure changes. If you are lucky enough in an ET, you will always have a upshoot and a downshoot, which again goes in favor of a DRS. Again, look for distance near disparity, which is very, very obvious in a 6-nerve palsy, not in a case of DRS. The next important caveat would be to look at the old photographs. Like this child came with the movement limitation, which has been there from a very long time. You ask him the history, the child, this is at the first birthday, this is third birthday, fifth, seventh, always had this. So it's a case of congenital 6-nerve palsy, though it is rare. So old photographs or photographs looking at is very, very important. Again, this is another child who the mother says the child has been squinting. When I look at it at the clinic, he's apparently completely okay. The old photographs, couple of them, absolutely stained. Call him on another day, the child has a ET. So this is a case of a cyclic esotropia. So you have days with esotropia, days without it. So always look for old photographs before you conclude that the child does not have a esotropia and send him off. Now, when we have diagnosed that this is probably one of the causes or what the diagnostic clues that you have to pick up in a case of esotropia, let's look at some of the surgical caveats. Timing of surgery, again of importance, especially in a case of infantile esotropia. The limbus insertion distance, again in esotropia, and handling paralytic and restrictive etiology. A few cases before I conclude. So this is an 8-year-old child presents with squinting from the age of 1 year. The child has good vision because of cross fixation. So obviously you would chosen to do a 3-muscle surgery and correct him. So in any case of infantile ET, even when you're operating later in later age, always look at limbus insertion distance. Like in this child, it was only 4.5 mm, not 5 mm. So your surgical calculation would differ based on it. In the second case again, 8-year-old child presenting with diplopia. The child was apparently normal, cycloplegic refraction almost okay. So this is how the child was a year back also before she came to us. So got a neuroimaging done, ocular movements normal. The esotropia is comitant. It's around 50 to 55, gaze, the distance near disparity none, gaze angle disparity none. So this is a case of acute acquired comitant esotropia. Again requires surgery after 6 months, no change, underwent surgery. This is a gentleman with esotropia, apparent abduction limitation, small amount of upshoot. Case of DRS, you would choose between SRT or a bimedial recession. The last case, what we were looking at in the congenital 6-nerve palsy. So you have options in terms of full tendon, partial tendon, or a modified Nishida. Modified Nishida proves effective in this particular scenario. Again, don't forget to measure axil length in certain cases of extreme ET. Like in this gentleman had around 30 millimeter in the right eye, left eye has 29 millimeter. The most puzzling part of his eye was the right eye was left aphakic. So the refraction was only +1. So unless you did the axil length, you would never come to a conclusion. Again, this requires a lobe myopexy. And so in summary, always use the appropriate diagnostic tools to sum it up, and then come to a diagnosis based on what jigsaw puzzles that you are able to finish, and then choose the procedure accordingly. So esotropia needs a methodical approach like any other squint evaluation, vision evaluation, detailed evaluation of squint, arrive at a diagnosis, and then conclude. So this is a list of comitant and incomitant esotropias that you would normally look at. So any squint, there's no magic in the magic per se, it's always in the details. Thank you very much.
Thank you, Dr. Sowmya, for that excellent presentations. I mean, a lot of things going on. You're doing surgeries as well for simple cases, and the complex cases, of course, it's you have to decide case to case, because obviously the risk involved in those cases, and probably you might not be able to give the result which is desired by the patient. So counseling is very important in those cases. And sometimes in these younger patients who are like you have a small angle esotropias, probably the parents are quite bothered. So in those cases, probably what do you consider? Do you ever feel the need to give botulinum toxin in these patients?
Yes, you could. Again, it largely depends on the case. If you're talking, especially in terms of acute comitant esotropia with a small angle, yes, Botox can be one of the options, but I have a limited experience with Botox.
Thank you.
We have given in acute onset ET, like this COVID times we have given. Neelam, I think you are presenting in your presentation, I think so. We already presented also, and it is with free paper we presented.
Okay.
If it is done early, it gives very good results.
Very good results.
MRI being normal, and then you give the Botox, it works well. We saw this in this recent COVID times when we had all acute ETs and myopes and all that. In acute ETs, it works. But if it crosses that 6 months, then it doesn't really help so much. So earlier the better.
Congenital sixth nerve palsy is also quite rare. So do you do neuroimaging in these patients? I mean,
Sorry.
congenital sixth nerve
No.
is quite a rare thing to have.
Yes.
So when do you do neuroimaging in these patients?
This child presented to me only at 8 years of age.
Okay.
So I still got a neuroimaging done because the diagnoses were very obvious from the photographs.
So we had a slow growing tumor in one of our sixth nerve child who was gradually on the diplopia was worsening.
Okay.
So obviously, I mean, that's why in these cases imaging should be done in the sixth nerve.
Yeah. I had one interesting case. A child with progressive myopia actually come with a small angle esotropia. Very recently, one of my colleagues' relative brought in with a small angle esotropia, had a very early onset sixth nerve paresis. Imaged her, she had a neuro tumor which came up. So that was not picked up, thinking it is an esophoria with myopia. So.
Thank you.